So, and here you can see the incisal show at rest. So she started off with 4 millimeters, she ended up with 2 millimeters, which is within the ideal range. And this is from a profile side view, so you can see how we intruded and how we improved the torque of her incisors. And this is CBCT comparison. As I said, I take CBCT as part of my standard records. And you can look at things carefully and very accurately and quantify the changes, better than 2D superimposition. So you can see here that we see the effect. It's a very minimal auto-rotation of the mandible. You can see how the mandible swings a little bit forward. And this is from this view as well. So you can see the red is after, you can see the before is the white. You can see how the mandible changed a little bit in position, and this is how we corrected our class 2. And you can see here probably we got about 1.5 millimeters of intrusion, and the auto-rotation we got a little bit of 1.5 millimeters of movement. It's very minimal, but it was ideal for that patient. Now, this is a more challenging case. So this is a case that came to me, and as you can see here, one of the things that you will notice is that she has a cant in her smile. Looking at her intraorally, so you can see she's class 1 malocclusion, a little bit of spacing, but really, if you look at her CBCT, one of the things that you will notice is that she has a facial asymmetry. Facial asymmetry is very, very technically difficult to treat. It's because it's not just one problem. People usually look at the maxillary teeth, but really it's the whole facial complex. Even the level of the eyes, and you can see the mandible shifts and all of everything shifts around. And if you see here, you can see the cant that she has. So of course, when a patient walks to my office this way, I always tell them, listen, you have this problem. If you want everything to be treated ideally, you should consider orthognathic surgery. But many times, some patients don't want to do orthognathic surgery. As you understand, it's a big procedure. So then we provide some alternative solutions if they are compliant with the elastics and the TADs. So here, again, looking at the eyes level, and you can see the gradient in terms of the cant that she has in the gingival levels, the lip, and the incisors and canines. And of course, if you look at CBCT and do some measurements, you'll also find that there is some difference at the canine level and at the molar level as well. So the good news is this. So from a layperson's perspective, and this was published in the AGODO in 2014, and what they found is that the asymmetry in the gingival margin at the central incisor level for lay people is usually identified at a 2 millimeter difference. Now, as clinicians, we can identify 0.5, but lay people cannot identify beyond 2 millimeter. Same thing when it comes to the canine, again published in the AGODO in 2014, and they found that for canines, 1.5 millimeters and 2 millimeters. So we do have a little bit of leeway from a layperson perspective, or what we would so call a social smile perspective. So this was her clin check. So here again, we're just, I'm doing this. I'm trying to intrude the upper right side. I'm trying to extrude the upper left side, intruding the lower left side and extruding the lower right side. I'm trying to kind of mask. I'm trying to camouflage the skeletal asymmetry that she has. And this is what I'm trying to do here, and a little bit of aligning the upper and lower arches. So, of course, I told her I have to use TADs to intrude this amount and to differentially create force vectors to kind of tilt the occlusal plane. I needed some TADs on the upper right side. And this is where I place TADs to be able to intrude here, and also a palatal TAD in the palate between the two premolars. Now, you can see after the intrusion, you can see the effect how we intruded the upper right area. Now here, when I finished this case, what I was doing is, again, I want to encourage extrusion on the left side and encourage in the upper left side and encourage extrusion in the lower right side, right? Because I want to tip her occlusal plane. So here I used the TAD, I cut the aligner at the premolar level. I wanted the lower premolars and molars to extrude, and at the upper left side, I cut the aligners at the level of the first premolar to encourage these teeth to erupt. So I'm differentially choosing how I want to settle her occlusion. This is basically what we did here. And then we further wanted to mask the camouflage because or camouflage the asymmetry. And here Dr. Al-Hamidan also did a CAD-CAM fabricated guide, but what he did here is he did an asymmetric guide. So you can see the upper right side was designed to have more bone removal than the upper left side. So we're masking it orthodontically, we're masking it periodontally to achieve ideal results. This is the guide, and this is during the surgery. And as you can see here, so more removal on the upper right side. And this is her final results. You can see beautiful sucked in occlusion, upper and lower, nice alignment of the upper and lower arch. And before and after, you can see midlines on, beautiful occlusion. But most importantly, let's look at her smile. Huge change. Agreed? So you can see how before and after for something that is ideally treated using orthognathic surgery. Yes, it is not ideal. Yes, it was a challenge. But from a layperson's perspective, from the patient's perspective, she was ecstatic. She loved her result. She was so happy about it. And this is her before and after. You can see here, and you can see the difference in the levels of the lips and the gingiva and the teeth as well. So not ideal, but pretty close to being ideal. Before, after Invisalign, after orthodontic, after aesthetic crown lengthening. So you can see a huge change for her. And here, before, after Invisalign, after aesthetic crown lengthening. All right, what happened to CBCT? So again, I took a CBCT for her, and what was interesting to find, and I didn't expect to see this, you can see that the mandible actually is posturing itself into the right side. So because I intruded, the mandible kind of auto-rotated in a horizontal vector. This is something that is impossible to see or quantify using 2D X-rays. And this is where the 3D X-rays are really cool in looking at this change. So you can see how the mandible shifted a little bit. That helped with the midline as well. Now, what did we do here? So we intruded about maybe 1.5 millimeters up to 2 millimeters, depending on where you do the measurements. Now, one of the things, of course, that I want to look at her condyles. What's going on? Is the condyle severely displaced? Probably there is some rotational movement, but it's very, very minimal. So at that level, just doing the CB superimposition, I didn't detect much change, which means it's probably within a comfortable region within the hair-centric relation. And this is a case that was actually referred to me by Dr. Hamidan. We examined her together. It's one of the things that we do in our practice. We do a joint examination. And when she came to him for aesthetic crown lengthening, so he called me over. He said, take a look at this girl. And as you can see, so she has a big smile. So as we said, not all gummy smiles are the same. So here you can see, this is her from a facial balance view. So you can see increased lower anterior face height. You can see how gummy her smile looks. And this is from a side view. So you can see she's a class 2 malocclusion. She does have very retrographic chin. And she has the excessive vertical maxillary excess here, as you can see. Now, of course, again, what are our measurements? Upper lip length in saddle short wrist is a must. So here, the upper lip length is within normal limit. So yes, it looks a little bit long, but it's still within the higher range of the normal limit. But even though her incisal short wrist is about 6 to 7 millimeters. So that's a lot, and this is something that is difficult to do even with mini screws. So I told her the only way to correct this is using orthognathic surgery, and I consulted my good friend Dr. Yusuf Al-Mu'min in this case, where he did a fabulous job, as you will see in a second. So again, here you can see she's a class 2 skeletal and dental malocclusion, as you can see on the left side and the right side. So we want to do impaction and advancement also with a genioplasty. So this is our CBCT, and this is our Invisalign ClinCheck. So here you can see what we are doing. Okay, so of course we extract their wisdom teeth. Now in the ClinCheck plan, if you're an orthodontist, sometimes the software doesn't allow you to impact and advance. But really, you just need to mimic the final movement. So just the mandibular advancement is equivocal from a dental preparation standpoint, as if you're impacting and advancing. So you just need to see this final surgical jump, regardless of if you're impacting as well. You don't necessarily have to reflect it onto the ClinCheck. And you can see this is what the plan was. This is how she looks after surgery. And orthodontists, I've been doing a lot of Invisalign and orthognathic surgery, something that I lecture on a lot actually internationally. And I've built my experience to it. I think it's an amazing tool. You can do it, but you just have to understand and look at some of the things that you will face and feel comfortable with it. So this is how our occlusion looked after surgery. Now, many orthodontists would be scared. They'll freak out if they see this. But really, it's not a problem at all. Just pop on some brackets, buttons, sorry. And then you can differentially play with how you want your trays to look and trim your trays accordingly. So you'll see here. So you can see here, I trimmed the trays in certain areas like the lower left side because I wanted to encourage the extrusion of that portion and running some elastics. And then I did a refinement for her. And this was her final result. So you can see before and after. Before and after. So huge change for her smile. Before and after, excellent class 1 occlusion, as you can see on both sides, midlines are on. And this is her cephalometric before and after. And this is CBT superimposition. You can see the amount of change that happened. I really have to commend Dr. Mu'min for the change that he made. You can see the amount of expansion and the movement of the mandible. So huge change. This is something that is not possible. It's without the boundaries of doing it just periodontally and orthodontically. And this was the amount of impaction. We have about 0.9 millimeters in the upper front and 4 millimeters in the back. Dr. Hamidan. final remarks.
I think we would just like to close up with this statement. I always tell this. I learned from Dr. Sulaiman. If I've ever seen further, it's because I stood on the shoulders of giants. It's because I learned from him, and I hope he learned from me. So with that, remember that all cases are not the same. So don't think of them, they're all the same, because they're not. Every single case is special and has to be, every single case is special and has to be addressed in its own way. So with that, teamwork always works. So if you have a good team, you're in good shape. Thank you so much for your time. We appreciate the kindness and the hospitality. And hopefully you guys enjoyed the lecture. And if you guys have any questions, please fire up.
I'm going to have to say, I'm sorry, there's no time for questioning.
All right.
But thank you so much for the informative lectures, Dr. Hamidaan, Dr. Shaheen. We'd like to present our appreciation for the speaker, so please join in to show your appreciation. Thank you very much.
Thank you. Thank you. Good job. Thank you so much. That's a big tooth.
Thank you so much.
Thank you.
Thank you.
Sorry, Dr. Fawaz, for taking over the time.
honored to introduce yet another former colleague, Dr. Fawaz Azzouri. It's open. Hello, here we go. Okay, again, I am honored to introduce yet another former colleague, Dr. Fawaz Azzouri. Dr. Fawaz Azzouri graduated from Kuwait University, earning his bachelor's in medical sciences and dental medicine with honors. He then completed a 2-year advanced education in general dentistry residency at the University of the Pacific, San Francisco. After that, he pursued advanced training and education in implant dentistry in Oakland, California. Dr. Azzouri earned a master's and a doctorate degree from the University of the Pacific, concentrating in healthcare and dental education, and he received several scientific and research awards. He is currently an associate professor at Kuwait University. Please welcome Dr. Fawaz Azzouri.
Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First, I'd like to thank the organizing committee for this kind invitation. And I'd like to thank you all for being here, and I really hope I add something to your knowledge and experiences. I'll be presenting a topic today that is gaining a lot of attention, not only in our clinical practices, but also in the dental literature, which is the rehabilitation of the completely edentulous patient with implant-supported fixed prosthesis. Looking back at the questions I get regarding the topic, and what seems to be trending in the dental literature, it seems to me at least that it's revolving around using digital tools in our daily workflow. And to me, there seems to be a lot of misconception, especially when we realize that there is a lot of colliding statements between marketing claims and the scientific evidence. I'll be sharing some of my humble experiences today with some of those developed tools and provide an overview from the literature to help really demystify some of those misconceptions. But first, let's start with the gold standards. Let's start with the conventional workflow. We've been doing that for more than 30 years now. It's been working relatively well. So this is basically this is the reference that we are comparing to any innovation to, simply because it's been working and this is considered the gold standard. So when a patient pretty much comes and shows up to our clinic completely edentulous, we typically start with making them a new set of dentures. Then we go ahead and replicate those dentures into radiographic stents. We can either use barium sulfate, fiducial markers, or gutta-percha. Send the patient for a CBCT scan where we can really relate our planned outcome to the anatomical limitations that we have in this patient. Then we basically simply convert that radiographic stent into a surgical stent, which will help us really facilitate implant placements during the surgery. Personally, I've always believed that immediate loading for the full arch cases is a wonderful service that we can provide for our patients, given that we respect certain criteria. So if you are immediately loading those cases, we are simply basically converting a removable prosthesis into a fixed prosthesis. Now, for those of us who do this, we do realize that it is a lengthy process. It is very messy as well, but it does result in very good outcomes. Then I typically have the patient wait around 3 to 4 months for them to heal, and in this case, thankfully, they healed uneventfully. And if you're lucky, they typically heal up like this and come back for the restorative phase. I start with an initial impression using stock trays and putty, just to capture the three-dimensional orientation of the implants intraorally. Now, obviously, this is not accurate at all. It just helps me with the next phase, which is basically making a sectioned resin jig with custom trays that will help in my final impression. I go ahead and secure the impression copings into the patient's mouth with the section jig, splint them together, and go ahead and do my final impression using the custom trays I did. Go ahead and pour my master cast, and to me, one of the most important steps in that process is verifying your master casts. And typically, we use verification jigs for that. For those of us who are not aware of that, this is basically a tool that verifies your master cast. So if that tool is well seated on the cast and in the patient's mouth, then we have pretty much a verified cast that we can work from. Next, we go ahead with our jaw relation records and our flangeless tooth try-in. After the patient approves the try-in, we go ahead and work with our CAD/CAM specialist. In this case, it's my good friend Dusan Mihailovic from Deutsche Dental Lab, where we kind of sit down and have a discussion about the design of our prostheses. We can definitely do either the final or the interim prostheses. I always advise to start with the interim prostheses. Again, you don't want to really bet on the final prostheses yet, especially at this phase. And this is really why I truly believe that we don't have a truly conventional analog workflow. I think there will always be a digital component in those cases, simply because we really can't afford the inaccuracies that we are associated with conventional methods of waxing up the femur, casting, and all the inaccuracies associated with that. So I think this is why we no longer have a truly analog or non-digital workflow. After that, go ahead and mill my, in this case, polymethyl methacrylate temporary, deliver to the patients, and I typically have them function with it for a couple of months before they come back for the final. Now, if you do your job well with the try-in, you don't have many feedback from the patients. Typically, patients are very happy with it. Keep in mind that they were already completely denture, so those are the patients that typically would be happy with the least, to be honest. After that, we can just simply replicate the design that we used for our temporary into our final product. In this case, it is it's a zirconia-based framework. So to reflect, I think we had a very satisfied patient. Not only we met her expectations, actually, we exceeded her expectations. Myself, as a clinician, I'm relatively proud of what I provided for that patient. So why change? Well, let's not think of it as change as much as natural evolution. I think it's human nature to make things easier, faster, and less invasive. And in the implant field, when we think about things that are easier, faster, and less invasive, we typically think digital. So regardless of the reason on why we implement digital tools in our daily workflow, I think we really need to understand how those tools are implemented and identify missing links to help better serve our patients. Now, I think anybody can make an argument for or against those reasons, but again, I think identifying missing links is very important. So let's start with the next case, which pretty much we infused a couple of digital tools in it. This is a 56-year-old gentleman presenting to my clinic with what we refer to as a terminal dentition. Now, for those of us who are not aware of what a terminal dentition is, it's basically a dentition that is not expected to survive for the next 3 to 5 years. And typically, the treatment of choice is completely dentalism. So after going back and forth with the patient and the patient's physician, we decided that this patient is a suitable candidate for full mouth, or at least full arch in the maxilla for now. So we went ahead with our intraoral scanning. I also supplemented my 2-dimensional photos with 3-dimensional images from the 3D facial scanners. Now, the concept of this is nice because we can import and merge our data from our intraoral digital wax-ups into those scanners and have more of a dynamic evaluation of the case, at least by concept. I will be challenging this concept in later slides and kind of provide an overview of what the literature has to say about this. Now, we send the patient to a CBCT scan, so now we have everything we need basically to start our treatment. We can use softwares to merge data from the DICOM files and the STL files from our intraoral scanner. In this case, I used co-diagnostics. So as you can realize, we no longer need a radiographic stent because we simply can do this step digitally. Not only we can design our surgical stents, we can also design our interim prostheses that we are planning to immediately load. So now we can go ahead and print our model. Now, in this case, I decided to use sequential surgical guides because I thought that not all implants can be placed in the same manner. So I started with a surgical guide that facilitates the implant placement in the posterior. I also used a bone reduction guide because I wanted to do some alveoplasty in the anterior maxilla to facilitate the implant placement in the anterior. And then I went ahead and printed a surgical guide for the anterior implants. Now, please note that all those guides are called, or we refer to them as stackable guides, meaning that they are all stacked into a base guide. sorry, the pointer is not working, but basically you can realize that all guides are basically attached sequentially on a base guide with the extension arms that we are designing. So not only we can use this for our surgical guides, we can also use them for our temporary and stabilize our temporary, which we also printed with the extension arms that will fit on exactly the base guide that is consistently throughout the surgery. Then we take the patient to surgery, place the posterior implants. Next, we go ahead and place our base guide, do the bone reduction, extract, do the bone reduction, and go ahead and place the anterior implants. Now, in this case, we decided to immediately load using the temporary we already fabricated because we already fulfilled all the criteria for immediate loading. So what I typically do, I like blocking everything with rubber dam just to avoid having any acrylic going into the undercuts of the abutment or worse, the suture sites. And I just simply convert that prosthesis into a fixed prosthesis using the extension arms. And after the acrylic sets, I'm sorry, the pointer is not working again. After the acrylic sets, I go ahead and section the extension arms that I already made. Go ahead, finish and polish, and deliver. And this is how the patient walks out of the clinic. So, alhamdulillah, a couple of months later, patient heals uneventfully. So what I do is I don't discard my surgical guides yet. I think there's a very good use for them in the prosthetic phase. So what I do is I remove those metal sleeves on the guide, and literature have shown that we actually don't need them anymore. Section the guide, section the extension arms, and make a custom tray using the printed model that I already made. And use this as a splint for my impression coping. So no longer I need an initial impression that I need to make those sectioned jigs. So in a sense, I really minimize my workflow with one visit. Go ahead with my final impression. Master cast, verification jig, setup, and I always like using 3 abutments in a tripod fashion. And I always connect them to the base plate. I think this is a very good way to secure your base plate and have a much more accurate interocclusal record. Go ahead and try it in the patient's mouth, have it approved, and then go back to my good friend Dusan to start planning the prosthesis. And again, in this case, it was an interim prosthesis. What we can do nowadays is use optical jaw tracking systems to help replicate mandibular motion and import it into our software. In this case, it was Exocad. This is nice because not only it will replicate mandibular motion for you, it will also translate maxillomandibular relationship digitally. So in a sense, this is a digital Facebook. I was very fortunate to be introduced to that a couple of years ago when I was spending my sabbatical in San Francisco. And I'm happy to say that this is also available here in Kuwait. So we can import the data and the motion digitally so we can replicate it into a interim prosthesis. Of course, you can always replicate it into final prosthesis as well. Went ahead and delivered the case, and this is how the patient walks out with the temporary before and after. So in this case, I'd like to highlight 2 strategies that I used to kind of help me with the case. The first one is guided surgeries, and I really want to dissect and see what the literature has to say about guided surgery. So we all know that guided surgery or computer-guided surgery is not something new. Actually, one of the first reports came out were in the early 2000s describing the use of it in completely edentulous patients. And now we know 3 types of guided or computer-guided surgery. We have the static system, which is very familiar for us. We've been using it for a while. We don't have any major problems with it. However, one of the major limitations is that we really can't change the trajectory of implant placements. And many times during surgery, we do need to do that. So if we need to do that, it's probably going to be useless during surgery, and we need to switch to freehand surgery. The next type is the dynamic navigation system, which is also a form of computer-assisted surgery that uses optical tracking to help facilitate implant placements without the physical restriction of a surgical guide. Now, a lot of people assume that this is something new. Actually, it's not. We've been introduced to that back in the early 2012, 2013. However, nowadays, a really big company acquired that company and kind of rebranded and are heavily remarketing for it. The third and final type is robotic, or what we refer to as haptic. Basically, the whole purpose of this is just to combine advantages of both the static and the dynamic systems. So let's see what the literature has to say about those. Unfortunately, the literature is very scarce when it comes to that topic, especially with the fully edentulous case. Looking at this paper, which beautifully describes the differences between those three, and when you look at this graph, you see that the majority of studies were done on static. And when we compare the numbers with robotic and dynamic, we really don't see much of a difference between those two systems. Keep in mind that most of the studies were done on the partially edentulous cases, especially with the haptic, robotic, or dynamic system. So I think we really need to be careful about going into unexplored territory and invest a significant amount without the proper scientific evidence and backup. This is also another paper basically concluding that there was really no significant difference. Now, another topic that I find very interesting is the current push for facial scanners nowadays in the market. Now, by concept, as I said before, this is very interesting because we can import the digital data that we have in our softwares and merge it with the facial scanner so we can have more of a dynamic, facially driven planning, at least by concept. But like all other data acquisition methods, we do face inaccuracies. And this is okay, given that those inaccuracies are within clinically acceptable range. Even PVS impressions, which is the gold standard, has inaccuracies, which is fine. So do we know what is the clinically acceptable range for facial scanners? Well, from Piedras' papers, he reports that if your facial scanner is within 1 millimeter of deviation, that is considered clinically acceptable. So do we have evidence in the literature for commercially available scanners to claim that they are accurate? Well, before talking about the accuracy, we really need to understand how accuracy is being evaluated in the literature. Accuracy is simply a combination of two factors, trueness and precision, where precision is the closeness of agreement between different test results, and trueness is the closest of agreement between arithmetic means. Now, to make this a bit more visual, trueness is basically how far is your image, or is your captured image, relative to the original object. In research, we call this validity. Now, think of this as those black dots. How close are those black dots to the bullseye of that target? Now, precision is basically how reproducible is that image. In literature, we call this reliability, meaning that how close are those black dots together? Now, in an ideal situation, we want something that in statistics we call a northeast relationship, where one variable benefits from another. So we really need, what we really need in the system is to have a high trueness and high precision. So do we have studies that actually claim and relate that to our currently available commercial scanners at least? Yes, we do. And when we compare it to the clinically acceptable 1 millimeter, it is reported that for commercially available scanners, we have a trueness of between 140 to 1,330 microns. This is a relatively big number, while precision is between 10 to 100 microns, which is pretty much acceptable. So let me rephrase this. If you are using commercially available scanners, you are consistently inaccurate. Now, keep in mind, this is only for facial features. We still didn't talk about merging the data from our intraoral scanner, which is the whole point of doing that, especially in the implant field. This might be very beneficial for the orthodontic field, but when we're talking about the implant arena, it's a different ballgame. Again, the whole purpose of this is basically to merge our findings from an intraoral scanner to the facial scanner. Now, we really need to understand how that merging process is. Now, if you recall, in that case, what we did is we also merged our data from the intraoral scanner to the DICOM file so we can make our surgical stents. Nowadays, we have the luxury of working with best fit algorithm softwares where they actually facilitate that alignment. Nowadays we have this where they can facilitate, as opposed to what we used to do before. When I first got engaged when doing research with this, we used something called zero access method, which is basically almost like manually aligning the files, and you can realize how much errors that we can face. So, sorry. So common information between both files is very important, so we can have information merged together very accurately. Now, the problem is that the common information between intraoral scanner and facial scanner is not much at all. In the facial scanner, we have teeth, and in intraoral scanner, we have teeth, which is considered common information. However, the problem is that facial scanners distort teeth to a certain extent. It makes it really inaccurate, makes that merging process inaccurate. And this is where I believe artificial intelligence can be of good help in identifying similar patterns, but I think no commercially available scanner yet or software is available to do that. So a lot of authors suggested using extraoral scanning, extraoral scan body systems, basically to facilitate that merging process. So think about this as a translator between both files. For this, we do have data, we do have evidence. Now, no one even bothered to do a study about direct alignment between those two files because it's simply inaccurate. It doesn't make sense. It's probably one of the most inaccurate things to do in dentistry. So for this, we do have evidence, and we do have some pretty recent ones. A couple of them are not published yet, and inshallah, they will be published next year. Now, here comes the punchline. Trueness is reported to be between 350 to 2,350 microns, while precision is between 400 to 2,000 microns. Those are extremely big numbers when we compare them to the clinically acceptable 1 millimeter. So again, before making a big claim about facial scanners, we really need the scientific backup of it. And I like what I say. I like what I say in research. Claims need evidence. The bigger the claim, the bigger the evidence needed. Let's take another case here of a dear patient of mine presenting with a terminal dentition in the maxilla. Extraction was done, implants were placed, and now we're ready for the prosthetic phase. Now, I highly advise you to implement two workflows if you are going into digital. I personally do that. I like implementing a digital and supplementing it with an analog, or doing an analog and supplementing it with a digital. So let me share my results with you with my analog workflow. Again, if you are still practicing analog workflow for the completely edentulous, you are doing great. Don't feel left out about implementing digital for the fully edentulous at least. So in this case, I decided to do a prototype, something which I really advise everybody to do for those kind of cases, and I'll be talking about prototypes in a bit. And as you can see, the prototype was seating very well on the master cast and the patient's mouth, indicating that our data acquisition was acceptable. Now, let's see my results with the digital workflow and see if I was as lucky. So, one tip I would like to give is that if you're implementing digital workflow, even for the partially edentulous cases, have the scan bodies face in different directions. And I think knowing how the algorithm works, this really optimizes your scan. Go ahead and print your model. I like removing the soft tissue replica to better evaluate the seating. Now, even with using the same prototype that I used, we still don't have a well-seated or well-adapted prototype. And as you can see, we have major inaccuracies and distortions. So this brings me, So luckily, we had the master cast to work with, and I kind of finished up the case, and the patient was very happy. Before and after images. Now, this brings up a very important question. Can we really claim that digital impressions for the completely edentulous patient are as accurate as analog impressions? Or are they as accurate as digital impressions for the partially edentulous cases? The answer is simply no, and I'll be dissecting the literature in the next couple of slides. So as I said before, this has been a topic of really a big attention in the literature. Many studies have been done to kind of report accuracies of full arch scanning. And basically, they realized that we do have a problem with full arch cases, and many studies have been reported indicating how many factors, or the factors associated with those inaccuracies. This is to name a few, and I can easily add 2 or 3 more columns. Now, the majority of those factors are so small, and alone, they are insignificant. I mean, those factors can be as small as sending the file to the lab. So what we do when we send the file to a lab is basically we compress that file. And now, by the way, the form of the file actually differs. So it differs if you're sending it on PLY or STL format. So we compress that file, send it to the lab. The lab goes ahead, opens that file, expands it, and starts working on it. Now, for the partially edentulous cases, that might be okay. For the fully edentulous cases, you do lose that data because of that conversion process. Now, again, very small factor that alone might not cause significant deviations. However, when we add up all those small factors in the completely edentulous case, we have something that we refer to as a cumulative scanning distortion. This is clinically significant, and this is the major problem that we have with completely edentulous cases. Now, I'd like to really focus on the most significant factor, at least to me, is the absence of fixed references for the completely edentulous. Now, scanners work great for the partially edentulous because we have fixed references. We have teeth that the scanner can pick up very easily. However, with completely edentulous cases, the only fixed references we have are those scan bodies. The majority is soft tissue, which we know that soft tissue distorts significantly when compared to teeth. And in a sense, this is why we established the altered cast technique to compensate for that basically distortion. So the literature describes two methods to increase and improve fixed references in completely edentulous cases, one of which is splinting, and the other is using artificial markers. Let's talk about splinting in a bit. So we know from our analog workflow, splinting works very well because it decreases micromotion from those impression copings, hence decreased distortion. So splinting works for the analog. So a lot of authors said, let's see if it works for the digital workflow. A lot of publications are out there. Those are probably the most cited, and from those studies, we know that splinting really doesn't work very well. Keep in mind that those are all in vitro study, meaning that they're all laboratory study. This led to a study that one of our very valuable PROS faculty, Dr. Kauthar Ali, to actually conduct a study on real patients, in vivo patients, and see the effect of splinting on those patients. And her results were pretty much coincident with the in vitro studies that we had. So splinting, maybe not. Let's see the effect of artificial markers, of adding artificial markers to improve scanning accuracy. Ryan Mazumoto's paper was probably one of the first to be published and describes using artificial markers and using several techniques to do that. His conclusions were a bit interesting. The first conclusion was, and recommendation is to use scan bodies with simple geometry versus complex. Techniques really didn't make a difference, and adding artificial markers did yield distortions of more than 170 microns, which is a bit beyond what we are looking for. What we are looking for is somewhere less than 150 microns. So artificial markers back then didn't work. So a lot of techniques came out. None of them were really validated with good research. Now, until this paper came out by Panos describing the double digital scanning technique, and this definitely was validated in later studies. So in his paper, Panos described the use of fiducial markers to basically increase the reference points. So he did is scan these fiducial markers on the temporary and on the scan body, and by doing so, the software can merge the data very easily, yielding to accurate models. I'd like to share my experience with this. I do have to admit that there is a learning curve, and I think this really changed the mindset for me, at least in my practice. I also have to mention that this only works for the maxilla. Fiducial markers were placed, scan was done, fiducial markers were placed on the temporary, scan was done. I always advise to do colorless scans versus colorful scans. I think colorless scans can pick up errors much easier than colored scans. Go ahead and merge the data. Again, supplement your workflow with the analog workflow. I still don't trust this 100%. Go ahead and make the model and fabricate your zirconia. I was lucky enough to have a very well-fitting model. And this is how the patient ended up. Now I'd like to emphasize more about the use of prototypes, which I think is underused in our region here. I think those are very valuable things to use, especially on those cases. For those of us who are not aware of what a prototype is, it's basically a replication of your final product. This really helps you visualize all parameters that are included in your final restoration, including through-axis trajectory. Now, as you can see in this case, this prototype was actually printed to the implant level, meaning that we don't have abutments attached to that prototype, which I think is very valuable and impressive. You can actually see stress patterns here after you deliver this model. If you look at this here, and we can definitely address this in our final restoration. But for now, I'd like to focus on the screw axis hole position. Now, for this, we have many ways to correct this. method that I like is basically using transmucosal abutments or multi-unit abutments to basically simply lingualize that screw access hole. Now I go ahead and attach those abutments on the master cast, scan using desktop scanners, and as you can see, I already designed that prototype to be around 2 to 3 millimeters short of the soft tissue, and I'll explain why in the next slide. Go ahead and print our next prototype, which as you can see is now on the abutment level versus the one that we did previously, which was at the implant level. Go ahead and secure the multi-unit abutments on the patient's mouth and secure the prototype. Now you can see that we have a space which I already intentionally planned on the software and on the design. This space will help me capture the soft tissue using a wash impression. So more or less now we have a very accurate final impression. We have all data needed. We have the position of the implants, soft tissue topography, teeth position, and even occlusion. But the problem is now is that we were working on an implant level cast. Now we have an abutment level case, so we need to basically convert that. Now, a typical way to do that is basically back pour or reverse pour your impression. And for those of us who do it, we know it's a relatively lengthy procedure. However, it does yield a very accurate master cast that we can go ahead and make our final prosthesis on. I'd like to thank Byte Dental Lab for providing such an amazing service. And this is how the patient looks after. And when we compare our after to the prototype, we see that we don't have much of a difference, especially when we replicate things very accurately. You do see spaces in the laterals and centrals, and we purposefully did that because we wanted to keep space for layering the lithium disilicate later. I also like, how are we doing on time? 5 minutes? Okay. So I'd like to emphasize on the use of transmucosal abutments because, again, I think that those are underused in our region here, despite how much that can facilitate the workflow. So not only those are helpful in correcting angular problems, they are very helpful in correcting vertical problems, like in this case here. As you can see in this case, the implants were actually placed at the bone level, but I had a problem that I had abundance of soft tissue. Now, I can promise you that if you fabricate any type of prosthesis, on this case, you will never get a passive seat. So to solve that, we used we used straight multi-unit abutments to basically shift that platform from more apical to a more coronal position, which we can easily work on and make our prosthesis. Now we face the same problem, converting an implant level cast to an abutment level cast. Now we can certainly go ahead and do reverse pouring or back pouring, but we do have a bit more sophisticated and a bit more digitalized ways to do it. Now we have scan body systems that can help us extraorally scan everything. We can basically attach those scan bodies to the prototype or the interim and scan things extraorally and basically have a very accurate mastercast that we can work with. I had some experience with it a couple of years ago, and I was told that this will be available in our market, inshallah, first quarter of next year. Now this brings me to the last case today. A very dear patient of mine. This patient is like 95 or 96 years old. Comes in with a big list of medical problems, a big list of medications, a lot of which are very potent blood thinners. So after going back and forth with the patient, his family, and his physicians, we really wanted to approach this in the most minimally invasive way as possible, and we really want to avoid any elective surgeries. Now, obviously, the anterior teeth needs to come out because it has significant periodontal and caries, which is also causing him a significant amount of discomfort. Now, luckily, the patient presented with good posterior implants that served him for many years, and they are still looking very good. So what we decided to do is basically do the scan, convert into colorless scans before doing anything. Go ahead and dismantle the implant crowns in the posterior, attach the scan bodies, convert into colorless scans, and then have a model printed. So next, I wanted to make sure that that model is accurate before going ahead and making that commitment of extracting the remaining teeth. So with the help of my colleagues, Dr. Asil Tamimi and Dr. Basil from Boxel, we went ahead and designed and printed a verification jig just to verify that our model was accurate. And this was probably one of my best days when I saw that, verification jig well seated in the patient's mouth, and I still don't have a very accurate explanation on why this happened. My personal input is knowing how the algorithm works with scanners. I think there is a problem with scanners shifting from one side to another by crossing the midline. And this is where I think some source of error is. So by maintaining the central incisors, I think we facilitated that shift between both sides and crossing the midline. Again, this is my interpretation. I could be wrong, but again, things worked out very well in this case. Now, we can go ahead and design our teeth position, occlusion. In this case, we obviously maintain the same VDO. Go ahead and trim the teeth on the model. Then go ahead and design and mill a temporary PMMA that we can use after extraction. Going back to the case, took out the teeth, delivered the temporary PMA. This literally took probably 3 minutes to do. And I'd like to thank my colleagues from Voxel for providing such a great service. And this pretty much sums it up. You can see here that no single impression was done. So to me, this is what I refer to as a completely digital workflow for implant rehabilitation. With that, I would like to thank the organizing committee for this kind invitation. I would also like to thank them for taking the initiative in supporting the Palestinian crisis that's going on now and supporting our brothers and sisters and children out there. So thank you very much. Jazakum Allah khair. Thank you.
Thank you, Dr. Fawaz, for a very informative lecture. We have time for questions. If anyone has a question for Dr. Fawaz.
Hello, doctor. Thank you so much for your lecture. I'm over here. I just want to ask you, are you having any problems when you're switching from a 3D printed prototype to a full zirconia or let's say full peak or whatever framework you're working with?
Well, if you verify your casts, no. And
digitally?
Completely digital?
Completely digitally. Like printed prototype and then switch it. Are you having any problems with the final zirconia?
Not with the workflow I just described. Maybe I haven't done enough cases to realize that, but so far, alhamdulillah, with the cases that I've done, I never had a problem with a well-adapted prototype that yields a inaccurate zirconia-based restoration. I'm not sure if that answered your question.
Yeah. Okay. The second question, sorry. Do you have any experience or on 3-on-6 prosthesis or 3-on-6 concept?
No.
When we use only crowns and we put them and section them, some of the doctors are doing it, instead of doing a full all-on-6 or all-on-4 without bond reduction. Did you have any problems if you have done it with the breakage of the crowns itself?
I'm sorry to say I have no experience with that, so I can't really provide any feedback.
Okay, thank you so much, doctor.
Sure.
Okay, if we don't have any questions, then we will just like to present Dr. Fawaz with our appreciation certificate.
Thank you.
Okay, so this would conclude the morning session. Now we're going to have a break for almost an hour, and then we're going to start the next session around 1 o'clock in the afternoon. Thank you very much.
It's about guided bone regeneration, and we are going to be talking about what are the main principles and techniques that I use in my daily practice and some of the research that I've been doing over the last few years to see how we can make this a very predictable and a very consistent technique in our daily practice. And as I always say, I want to acknowledge and thank a great group of individuals and colleagues throughout many different schools and many different countries in the world. All the research, the clinical data, and everything that I'm going to show, it's not only my work, it's the work that I do in collaboration with a great team of people, excellent periodontists, that we work closely together for many, many years, and that's what allowed me to be here today presenting these cases. So when we talked about guided bone regeneration, we have to talk about implant site development, because guided bone regeneration belongs to this group of techniques named after implant site development. And what are these techniques? These are techniques that have as an objective the prevention, minimization, and or reconstruction of deficiencies of the hard and soft tissues in order to create an ideal three-dimensional structure for the placement of a dental implant. And when we place this dental implant, we are not only looking at giving a restoration to our patients, we are looking for aesthetics, function, and long-term stability. And before I go deeper into the topic of guided bone regeneration, I would like to take a minute to talk about this definition. And there is something very critical about these first three words of the definition: prevention, minimization, and or reconstruction. And what I wanted to tell you is very similar to what Rodrigo Neiva has been talking earlier today this morning. Is about the prevention. Whenever we can, we should be saving teeth, as he explained very nicely just a few hours ago. Most of the defects that we are going to see today, most of the rich augmentations that we are doing today, we should be aiming in first place to prevent those from happening. And if we cannot prevent, at least minimize as much as possible the effects of bone loss. We know we have a lot of research throughout many, many years. We know how the alveolar socket changes. We know the volumetric changes that occurred in an alveolar socket after a tooth extraction. These are mostly characterized by the thickness of the alveolar bone. We know that when we have thin tissue, we'll have more collapse. But then regardless of the thickness of the bone, we will always have some volumetric changes in hard and soft tissues. But we also know that there is a great variety of techniques that we call alveolar ridge preservation. By doing these techniques, we can minimize the collapse, the volumetric changes that occurred after tooth loss. And that can save us and our patient from major augmentation procedures the day that we want to place the implant. And these techniques have been proven. They have been proven again and again to be very predictable and very consistent. We have tons of systematic reviews and randomized controlled trials in this topic, and we know that alveolar ridge preservation works great. So whenever we can, whenever we have a chance, we should try to minimize as much as possible performing these procedures of alveolar ridge augmentation. But now what we are going to be talking today is what happened when, because either we were not able to manage an alveolar socket properly, we did not have a chance to perform alveolar ridge preservation, or perhaps this patient is coming from somewhere else, a different practice, a different colleague, and then oftentimes we face with this situation in which we have no other choice but to augment the bone. We need to recreate, we need to regenerate that bone volume in order to place the implant in the ideal three-dimensional position. But tooth extraction is not the only reason why we have this type of defects. Nowadays, we are seeing a pandemic of periimplantitis, and a lot of the deficiencies that we see nowadays in our patients are coming from disasters that we see after implant placement. We place more and more implants, and most of those implants, as Rodrigo said earlier today, they are not going to serve the patient for a lifetime. A lot of these implants, sooner or later, they have some sort of complications, and we have great deficiencies in the alveolar bone. We also have, of course, periodontitis. Periodontitis causes bone loss. We have traumatism, and we have, so many times, we are the ones responsible for that bone loss. When we do extractions, we should be as careful as possible and as traumatic as possible in order to prevent these deficiencies. Whenever we have a deficient alveolar ridge, then in that case we have no choice but to augment the ridge. We need to recreate that three-dimensional volume in order to place the implant in the ideal position. And that's what we are going to be talking today. When we have this type of defects, what we want to do is place the implant, very importantly, as we will see later, in the ideal three-dimensional position, and we want our implant to be completely surrounded by bone at the end of the healing phases. And what does that mean? That means that we need to be aiming at having at least 1 to 1.5 millimeters of bone when we place the implant. If we place the implant with a very thin vocal wall or lingual bone, that bone will more than likely collapse and resorb through time. So if we place the implants with a very thin alveolar ridge, we should always be considering some sort of alveolar ridge augmentation. What we are going to be focusing today is in these type of cases. We see the deficiency on the left side of the screen. We see a knife-edge alveolar bone. And then in those cases, in order to offer our patients a fixed solution with dental implants, we have no other choice than augment. We need to reconstruct the volume that we lost for whatever reason, maybe periimplantitis, maybe trauma, maybe periodontitis, but we need to recreate and augment the bone volume in order to place the implant in the ideal three-dimensional position. But we should never forget that patients, they don't want bone augmentation. They don't come to our offices. They don't go to the school looking in order to augment the bone. What patients want to have is a tooth, a rehabilitation that resemble natural dentition. We should always be looking for function, aesthetics, and long-term stability. We cannot lose the focus when we perform this type of surgeries that what the patients want, they don't want bone. They want a restoration that looks and feels like a tooth. So when we have defects, there are many questions that comes to our mind. What type of material should I be using? What type of membrane? What type of implants? Should I be placing implants immediately? Should I do a delayed approach for the placement of dental implants? And the answer is that we have many, many different techniques. There are many different ways to treat a case, but there is only one biology. It does not matter whether we choose to do block grafting, whether we choose to do autogenous particulate material, whether we'd rather do an allograft, whether we choose a xenograft, certain type of membrane. There is only one biology. And if we understand biology, if we know why and how patients heal, we will be able to be successful and predictable with whatever material of choice we have. Consequently, we know that clinical success does not depend on the specific technique that we are using. There are a great variety. Over the last few days, I had a chance to talk to many colleagues, and we all use slightly different techniques, different biomaterials, different membranes, but we all are successful in our practices as long as we respect these biologic principles. It is true, however, that different techniques, different biomaterials, and different procedures, they have different advantages and disadvantages, and we should be able to use these specific considerations of every different technique and material to our advantage. What are the different factors that we should be looking at when we face bone augmentation? We should be looking at the bony walls. How many walls we have? How contained is the defect? The mechanical protection, the vascularity. The more walls that we have, it will not only protect our graft material, it will provide vascularity to our regeneration site. We should be looking at the biomaterials, different biomaterials, as Rodrigo pointed out earlier today, this morning, they have different resorption rates. Sometimes we may be benefiting from a material that is very slow resorbing. Sometimes we may rather have a different type of material that is going to give us better mineralization at an earlier time, so we can re-entry a little sooner. And of course, patients. We seldomly talk in meetings about patient selection, and this is something very, very critical. So that's why we have many different techniques, we have many different tools, and what we should know is how to use these different techniques and different tools to our advantage. Use the benefit for different types of membranes, use the benefit from different types of bone grafting, always to our advantage, depending on the different type of cases. But they all share the exact same biologic principles. What do we need when we are performing guided bone regeneration? We need cells. We need cells that form bone. We need osteoblasts. Without cells, we cannot have a bone augmentation. We need scaffolds. We need a structure that will let that in place for sufficient time for bone to form. We need a material and a structure that will prevent the soft tissues from collapsing. And it needs to have sufficient stability, and it needs to be in place for a certain amount of time that will let the bone heal, which heal much, much slower than the soft tissues, as you all know. And of course, we need blood supply. But what else do we need? What are the things we as clinicians can provide for the regeneration side to be as predictable as possible? This is a very often cited publication by our mentor back at the University of Michigan. We need primary wound closure. It does not matter if we like to do blood grafting, autogenous with xenograft, complete allograft, absorbable, non-absorbable membrane. For all of those, we need to achieve primary wound closure. We need to create space, and we need stability of our material. And of course, nowadays, we are looking for minimal invasiveness. We are looking for very adequate and delicate soft tissue manipulation. So let's take a look at a case that I treated many years ago. This is a patient actually from the University of Michigan. Patient came to the clinic because he has a cantilever held by the canine. And the patient came like this to the clinic, and we are gonna, for the purpose of this case, we're gonna focus on the dentulous area on the second quadrant. There is some other cavities, there's some other concerns, but the patient really wanted to focus on the rehabilitation of that canine and lateral incisor. When we take a closer look, we see a little bit of a vertical deficiency, mostly towards the premolar side. And when we look at an occlusal view, we can see a deficiency on the horizontal component. So even though we did not have a CVCT, we know that this deficiency is not only of the soft tissues, but in the hard tissues. So this is a case that we knew we needed bone augmentation prior to implant placement. We proceed with the surgical procedure. We do, of course, full thickness flap elevation. We want to expose the defect, and here we can see that little bit of the vertical component with the horizontal component also of the defect. And here we can see the day of the surgery, we can estimate more or less how much bone we are missing. What is more or less the structure that this patient had prior to losing those teeth. And this is more or less what we are aiming to reconstruct so we can place the implant once again in the ideal position. So we proceed. For this case, we stabilized a non-absorbable PDFE titanium reinforced membrane on the buccal side. We do 2 screws. We fill the defect with 100% allograft, bend the membrane to the parallel side. We use another push pin. We are not using screws in this case. I'm sorry, we are using pins and tags. Here we have a closer view of the buccal side. We trim the membrane to make sure that it's not in contact with the dental structure, that it's not in contact with the tooth, that it's not in contact with the root. And here we can see the intimate contact between the membrane, native bone of the patient, and that particulate material that is nicely embedded within the membrane and the native bone. We want to maintain and protect that biomaterial for the next few weeks and months, preventing the collapse of the soft tissues and providing sufficient time for the bone to form and mature. We close the soft tissues. We obtain, of course, primary closure. And we follow up this patient for the next few weeks. This is the follow-up of 4 weeks. We have already retrieved all the stitches. And when we see this case 4 weeks later, we know that unless something major happens, if this patient continues with normal healing, it will likely be a successful case. We already achieved all the principles that we were looking at. We already created new space. We already put our biomaterial, our membrane, very stable. It's not moving. We obtained primary closure. So it's just a matter of time until we can perform re-entry to see the results that we have obtained. Here we can see the result. Again, at 4 weeks, in a buccal view, we can see that that little bit of a defect, or the vertical defect, even though it was not the main purpose of this procedure, we also were able to correct it through this technique. Here we have a longer follow-up. In this case, we waited 6 months for re-entry, and we can see how we were able to modify this edentulous alveolar ridge before the surgical procedure to after surgical procedure. We can see an obvious increase in the volume in the area where we are going to place our implants. This is the day of the re-entry. At this time, I was no longer at the University of Michigan, so this is courtesy of my very good friend, Carlos. reopen the site. What do we want to see when we reopen a site? We want to see our push pins and our membranes in the exact same position that we left it 6 months ago. So if we see that, what we are going to see underneath is obvious. We're going to see a nice bone volume that we were able to regenerate. Here we can see a buccal view, and here we have the comparison between before, the volume that we were more or less trying to achieve, and when we had after more than sufficient bone for the placement of 2 dental implants for the rehabilitation of both canine and lateral incisor. Now the question is, when I'm looking at this surgery, was this surgery successful because the specific biomaterial that I use? Was the surgery successful because the specific membrane that I use, or the specific system for fixation of the membrane? And the answer is no. I chose all those materials carefully, thinking about what are the benefits, what do I need for this surgical procedure, knowing that they had a little bit of a vertical component, knowing that it was a significant horizontal augmentation. I chose non-absorbable membrane, but perhaps I could have chosen a different type of biomaterial, and as long as you follow those principles, that surgery could have been successful with a variety of different techniques. Why? Because we follow the principles that we talked at the very beginning. And as long as we do these things, we can be successful with different types of biomaterial, different types of membranes. So now the question is, how are we going to choose the material, the membrane, the technique, the fixation method most favorable for our cases, knowing that there is a great variety of tools that we have. Every day we have new tools, new bone grafting materials. And the answer is there is not a single technique, there is not a single membrane that would be ideal for all cases. We need to plan our cases in advance, and we need to execute case selection. Every patient is different, every case is different, and we need to use all the different tools that we have to our advantage. How do we do that? With evidence-based dentistry. And what is evidence-based dentistry? I tell this often to my students, and they believe evidence-based dentistry is using whatever article they just read. If an article says something and it works, then I should do that. Absolutely no. For me, practicing evidence-based dentistry may be different than my friend Ali, because evidence-based dentistry is not doing whatever article you just read, whatever the latest systematic review is saying. It is based on evidence, experience, and expectation. So we can all practice evidence-based dentistry in a slightly different way, and that is perfectly fine. So in order to classify these cases and make it a little easier, we're going to use a very, for me, in my opinion, the more comprehensive classification that we have for horizontal bone augmentation and vertical bone augmentation in dentistry nowadays. This is a classification published by Chiapasco in 2018, that they have 4 different classifications, 1 to 4. And when we review them one by one, we see that class 1 is when we are able to place the implant once again, very, very critical. We are talking about implant placement in the ideal 3-dimensional position. So we have sufficient hard tissue structure, we have sufficient bone for the placement of dental implants. However, we have a deficiency on the buccal side. We have a slight deficiency that sometimes we may need to correct that through either soft tissue grafting or bone grafting procedures. We move to the class 2, and as we are moving through the classification, they are starting to be a bit more challenging. What is occurring in class 2? We have sufficient bone for the placement of dental implants, but there is an exposure of the implant surface. We either have a fenestration, a dehiscence, or perhaps a complete exposure on the implant surface. In this case, when we have an exposure of the intraosseous part of the implant, we have no choice but to reconstruct, do some sort of alveolar bone augmentation through different techniques, but we need to augment the bone volume in order to cover the implant surface. Class 3 cases, they start becoming more and more challenging as we move on the classification. And these cases are very important, and sometimes the ones that are the most tricky, because in these cases, oftentimes, we have sufficient bone for the placement of dental implants, but not in the ideal 3-dimensional position. We used to do that 10, 20 years ago. We don't do that anymore. We need to place the implant in the ideal position. So if we have bone, but we don't have that bone when we need the implant to be, we will be performing bone augmentation and then placing the implant in the ideal position. And class 4, these are more severe atrophic ridges in which we have an horizontal, a vertical component, and the placement of dental implant is simply impossible. Not in the ideal position, not in any other position. The bone volume that we have available is so deficient that we cannot proceed with implant placement. And now we are going to be reviewing some cases throughout the different classifications and seeing how we can manage all these defects from class 1 to class 4 defects based on the chiapascular classification. The class 1, as you know, these are the type of defects that we have a slight deficiency on the buccal side. And here we have this case, posterior mandible, missing a first molar, and both second and third molar, they are planned for extraction. We have a perioendo combined lesion on the second molar, as you can see, cavity, overhang restoration. So our treatment plan is to the placement of a dental implant in the position of the first molar, and then an immediate implant in the position of the second molar for the rehabilitation of the posterior quadrant in the mandible. Here we have the clinical picture after extraction of both the second and the third molar. And here we have the implant placement. Implant placement on the second molar in a semi-immediate implant position. And here we can see the implant on the first molar completely surrounded by bone, but we can still see that deficiency on the buccal side. We check our radiograph, we make sure that everything is in place, and what are we going to do in these cases? What is one simple and very predictable option that we have in these cases? We can perform soft tissue grafting. In this case, connective tissue graft that we harvest from the tuberosity. We placed it on the buccal side. Very simple, easy procedure, and we can see the patient 2 weeks later how we were able, without the need for bone augmentation, to correct that deficiency that we have on the facial on the buccal side. Here we can see a comparison between before and after, and we can see how with a very simple procedure we are able to correct those deficiencies. And I know many times we place this implant, particularly in the posterior mandible, and sometimes we can place the implant and leave the patient with that small deficiency. If it is not an aesthetic concern, if the patient can clean well, as long as we have sufficient bone volume, we have a relatively thick buccal wall, we don't need to correct those cases. But what happens when we are facing these cases in the anterior maxilla? So many times it's not only about function and long-term stability, which we can achieve by placing the implant in the ideal position. Sometimes it can also become an aesthetic concern. So we can place the implant in the ideal position. We can see that we have a buccal wall that perhaps it could be thickened, particularly in the middle surface of the implant. But in these cases, we need to decide, are we going to do bone augmentation or are we going to do soft tissue grafting? And this is a question that we are right now evaluating. There is more and more research coming up in the next year about this topic. And the truth is, from what we know already, is that as far as linear assessment, when we measure the distance from the outer part of the implant surface to the outer part of the gingiva, there is no difference whether we perform bone augmentation or soft tissue grafting. With both techniques, we can predictably and efficiently correct those deficiencies. The issue is that we don't know yet what is the long-term stability. How susceptible are those implants for periimplantitis? What happens if patients don't have perfect oral hygiene? Is it better to have more bone or is it better to have more soft tissue? And these are questions that we need to answer in the upcoming years. Let's move to class 2, deficiencies. As a quick reminder, these are implants that can be installed. We have sufficient bone. We can place the implant in the ideal position, but we have either small fenestration, deficiency, or combination of both. Patient with a missing central incisor. We take a look and we realize that yes, we have bone mostly on the parallel side, but we have a deficiency. I mark here the deficiency is more or less like a cone shape, and this is sufficient in order to achieve primary stability of our dental implant in the ideal position. We proceed with the positioning of the implant. We always check that we want that implant with the screw axis towards the cingulum position, the placement of the dental implant, and here we have the buccal view. As we can see, not only the implant is exposed in the most coronal part, but we have a very, very thin buccal wall. We obviously need to correct this deficiency. If we don't do anything, we not only have a part of the implant exposed already, more than likely the remaining part that is today covered, it will likely resorb over time and we will have a complete exposure of the implant surface. In this case, we do a combination of a first layer of autogenous bond, we add some xenograft, and we cover with an absorbable membrane. We stabilize the membrane, we start closing the flap, and here is the radiographic analysis. And as we follow up this case, we can see up to 1 year follow-up with an excellent aesthetic result and stability of our dental implants. Let's take a look at another case. Once again, missing central incisor. Another patient. This patient is actually also from the University of Michigan. We can see that deficiencies in the soft tissues that even though we did not have a CVCT, we know that this deficiency is not only on the soft tissues, but also on the hard tissues. Here we have the radiographic analysis, and what happened with this patient is that this patient came to the clinic at the school because she had the extraction somewhere else, and she thought that the extraction was a bit too traumatic. She wasn't too pleased with the previous provider. That's when she came to school, and seeing what we saw clinically, we could tell that probably this was not the most gentle extraction. We actually found a little remaining of that root tip that was causing that chronic, very minor infection, very superficial on the soft tissues. We, of course, have to remove that remaining piece of the root tip. And when we have the soft tissue healed, we get rid of that little bit of exudate, we proceed for the surgery. And this is the view that we have as soon as we have, once again, our full thickness mucoperiosteal flap. We can see that tremendous defect. That probably is the exact position where we have the root of that central incisor. When we see an occlusal view, we can once again see the defect. And we start with the grafting. Why do I classify this as a class 2 based on CAPASCO 2018? Because at this time, I think I could have easily placed a dental implant. I have sufficient bone in the right position to place an imperial implant and simultaneously do bone augmentation. It was early during my residency, so I wanted to be safe, so I decided to do a 2-stage procedure, which there is absolutely nothing wrong about it. If we don't want to place the implant, we can place it at a later stage. The very critical part, the very important part is that we place the implant in the ideal position. We do 100% allograft. In this case, we use different types of allografts, DFDBA and FDBA, and we cover with an absorbable collagen membrane. We stabilize the membrane with different suture technique. Here we have the immediately after suturing, we let the patient go, and we of course follow up these patients for the next weeks in order to make sure that things are going in the right direction, patient is healing nicely. Here we have the 2 weeks follow-up where we remove the sutures. 4 weeks follow-up, we can see more maturation of the future implant site. We can see how we were able to augment the volume, and we can see how we have corrected that deficiency that the patient initially presented with. That concavity, that depression on the buccal side, we were able to correct it without the need for soft tissue augmentation, just by increasing the bone volume. Here we have a comparison on an occlusal view of how we had it, the clinical presentation before the surgery, and how with a small, simple procedure, we were able to augment the bone in order to create a more ideal structure for future implant placement. We proceed with the implant placement. We open a minimal flap. One of the advantages of this suture technique is that we don't have to open big flaps, again, for the retrieval of the push pins or the screws. We place the implant in the ideal position, radiographic control. Here we can see a comparison of the bone volume that we were missing prior to guided bone regeneration, and we obtained several months later. We place our clean abutment and we will send the patient to the restorative department to start with the provisional phase and the final restoration delivery. So what is this technique that you have seen for stabilization of the membrane with the suture? And this is something that we were discussing a couple of days ago in the hands-on for guided bone regeneration. And it's a technique that I've been using, I was going to say very frequently, but it's actually in 100% of my cases with absorbable membranes in order to stabilize the membrane. What we do is we go from the lingual or parallel side, we engage deep on the vocal side past the line where we do our periosteal release, and we want to obtain a very stable structure where we have our bone graft, our membrane. The purpose of this technique is to contain the bone graft so it cannot escape. We need to create a space where the bone graft have underneath the native bone, both sides the sutures, and on top the membrane. So there is no room for mobilization of our grafting process. Here we have some of the examples that were published some years ago when we have these techniques. And here we can see on the right side of the screen how the bone graft is contained. There is nowhere for that bone graft to escape in between both sutures, native bone, and the collagen membrane on top of the implant. Here we have another case. Once again, we place the implant with a small dehiscence on the most coronal part, but as you can see, very thin vocal wall. We know that vocal bone will more than likely collapse and resorb over time during the next following weeks and months after implant placement. We need to augment the bone. So we proceed with this type of technique for the stabilization of both the membrane and the grafting material, and we can achieve very predictable results with a very simple technique. When we published this technique, if you go back to the original article in 2016, we were working in very simple cases, always single unit implants, because we thought that the surgery technique would not be stable enough for major cases. As we have advanced and moved throughout the years, I'm applying this technique to many other different cases, and we are no longer using this technique for simple cases. When you have cases like this, implant placement, anterior maxilla, both our implants, we need to place them in the ideal position. If that means the implants are going to be exposed in the most apical part, so it be. We will continue with bone regeneration, and here we can see two different regeneration sites, both with their membranes and the particulate grafting material underneath, so we can cover that implant surface that was previously exposed. Of course, we do the suturing, horizontal mattress, simple interrupted, and here we have the follow-up after 2 weeks. We are even using these techniques for more advanced cases. This is one of the cases of one of my students back in the University of Oklahoma. This is early re-entry after tooth extraction. We knew we need to augment the bone because there is a big concavity both right and left side. What do? Our particulate grafting material, we cover with absorbable membranes, and we use the suturing technique to maintain the graft underneath the membrane without space, without room for mobility. When we close this surgery, only by the pressure of the soft tissues, that membrane and that grafting material can move. We need to prevent that mobility, not only during the surgery, but the weeks later, the months later, and give that bone sufficient time and stability to form and mature. What do we get with this suturing technique? We facilitate closure and we insert immobilization. I'm sure it has happened to most of you, and it has happened to most of my surgeries at the beginning when I wasn't doing this procedure. We see the defect, take care of our soft tissues, place the grafting material, place the membrane, everything looking great. We take a couple of photos, and when we try to close the flap, everything is moving. We go back, we try to push the bone graft underneath the membrane is moving, now the grafting is no longer where we want it to be, the membrane is moving. When we do this technique, because we are engaging deep in periosteum on the vocal side, we can move the soft tissues, we can close the surgical site without the bone grafting and the membrane moving. We are making everything a little tighter, we are eliminating those empty space. It's very easy to perform, and compared to other techniques for stabilization of the membranes, there is no need for retrieval. Many times we do big surgeries, big flaps for bone augmentation. We use screws or tensioner screws or push pins very deep in the vestibule. Some people like to leave them alone. Sometimes you go back to retrieve them, but we need to open big flaps again. By doing this technique with absorbable membrane, there is no need for big re-entries. So we obtain predictability and consistency. What are the benefits we can find from fixing absorbable membranes? And this is a very interesting article that was published recently last year, but they did 4 different groups. They had a control group where they created a critical size defect. They have a group with an unfixed collagen membrane, just positioning the membrane over the defect. They have another group also without bone grafting, but with a fixed collagen membrane, and they have one final group with a collagen membrane unfixed, but they added bone grafting in that critical size defect. When they looked at the results several weeks later, they realized that fixing the membrane, it enhanced the bone formation to the point that the group with simply the use of an absorbable membrane being fixed, they have very similar results to the group with membrane and bone grafting. So by fixing that membrane, we prevent mobility and we let the bone heal because it needs much more time than the soft tissues. How are we going to fix our cases? We have different choices. We have screws, we have pins, tags, we have suture technique. The only time where we cannot use the suture technique that we just saw is for non-absorbable membranes. The suture is not strong enough to maintain non-absorbable membranes in place. So when we are dealing with non-absorbable membranes, we have no choice but to use push pins or screws. When we are working with absorbable membranes, my recommendation would always be either pins or sutures. Screws, as you all know, if you use them with absorbable membrane, it starts rotating and it's not very good for the stabilization of the membrane. Here we have another example. We fix the membrane on the buccal side. We use 3 different push pins, and here we can see our implants. This is the anterior maxilla. The implants are placed in the position that we want for our future rehabilitation. Once the membrane is fixed, when we know the membrane will not be moving, then we proceed with the grafting of the site. In order to make sure that we remain on time, I'm going to skip the video a little bit. We do the first layer of autogenous bone, and then we add our substitute grafting material. We always need to overcorrect our defects. No matter what grafting material we use, there is always going to be a certain amount of collapse. We need to intend to grow more bone than we need, even coronal to the dental implants, even cover the cover screws. It's a good problem to have when we have more bone than we need. It is always better to have more bone than less bone. We proceed with the with pins on the palatal side, and we can see a very stable regeneration site. We know the bone graft cannot escape, and if in a case like that we achieve primary bone closure, we know that that's guaranteed success because the membrane is not moving, the grafting is not moving, and we obtain primary closure of this site. So let's move to class 3 defects. What are class 3? Class 3 were defects where we have perhaps sufficient bone for the placement of dental implants, but we cannot place the implant in the ideal 3-dimensional position. Consequently, we will not be proceeding with the placement of dental implants for these types of classifications. This is another patient that for many years had a fixed bridge with a canine as an abutment tooth. The canine was endodontically treated, and after many years, it may be decay, it may be his diet, it may be a functional habit, the bridge broke. It is too long of an adventurous span to do another fixed bridge over teeth, so he wanted something fixed, and we started the conversation talking about possible dental implants. We take a look at the site, we can see that remaining root tip still where the canine was, and we do our radiographic analysis. When we do this analysis, we realize that we not only have a big concavity on the right side of the screen where one of our implants should be, we have a big deficiency on the posterior implant should be not only the pneumatization of the sinus, but it also has been a vertical collapse of the alveolar ridge. Here we have the panoramic view of the sites. We are planning for the placement of 3 different implants for a fixed bridge over 3 fixtures. And this is the volumetric analysis that we do in order to study the case before we proceed with the surgery. We do full thickness flap, we evaluate the area, we can see the concavity, we can remove the remaining root tip of the canine that we have there, and we can access the maxillary sinus in order to perform sinus augmentation that we will need in this case. We have the 3 different areas of the surgery that are the most critical that we need to focus on, where our dental implants will be in the future. And here we can see that concavity on the left side of the screen with one of our implants will be. When we see this concavity, we know this is good news. This is something that we studied a few years ago back at the University of Michigan when we look at the influence of the concavity of the defect in the regeneration results that we obtain. realized, looking retrospectively at many cases of direct bone regeneration, that the more they contain the defect, the lesser the degree, the more predictable for bone augmentation. Why? Because of vascularity and because of the protection. The own bone from the patient is forming a cavity that is protecting our regeneration site. So we proceed with the surgery. We take care first of the maxillary sinus floor augmentation. Then we fix the membrane on the buccal side. We want to, of course, fill that concavity where we know where the implant should be. We continue adding bone. We add more bone where the canine root was, and then we put our absorbable membrane, which is fixed on the top part on the buccal side and on the palatal side. We cover the lateral window. I believe somebody else was saying yesterday or the day before that there is actually no need for covering the maxillary window when we access. That is absolutely true. There is no need, and when we look at the evidence as far as results, and so on, there seems to be no difference. Me particularly, I always like to cover the lateral window when we access the maxillary sinus because it's not only about mineralized tissue, it's also about prevention of the bone grafting from coming out of the maxillary sinus. One of my former students, a good friend, Ahmed Sedeki, back in the University of Oklahoma, we just published his thesis, and we were looking at the influence of the